Our next presentation will be by Susan Hansen-Engelhard, and she'll be presenting on dissociative identity disorder, a source of resistance in psychotherapy.
All right, thank you. So, a little bit about me. I'm from Florida. I've been licensed 28 years. I can't believe I'm saying that. I've done all kinds of cases and had lots of training and so forth. Generally, my specialties at this time are couples, dissociative disorders, and substance abuse. Not necessarily all in the same case, but sometimes. So I have learned a bit about dissociative identity disorder that I think is important for us as clinicians to understand, and maybe non-clinicians. It's a lot more common than was previously thought. So the dictionary definition of dissociation, we have dissociative identity disorder. So we're looking at various aspects here. So one definition is the separation of whole segments of the personality, as in multiple personality disorder, from the mainstream of consciousness or of behavior. So I've got several definitions so you can start kind of letting it sink in. But what is dissociation and what are the dissociative disorders? Dissociative disorders are characterized by an involuntary escape from reality, characterized by a disconnection between thoughts, identity, consciousness, and memory. So that's a little more complete explanation. And NAMI, the National Association for the Mentally Ill, has this discussion. Symptoms and signs of dissociative disorders include significant memory loss of specific times, people, and events. And that is because those things are dissociated. Out-of-body experiences such as a feeling as though you are watching a movie of yourself. Mental health problems such as depression, anxiety, and thoughts of suicide, and that is very definitely found in these people. They are very frustrated with the direction of their life, and after trying many things that don't seem to work for them, they have quite a bit of mental health problems. A sense of detachment from their emotions or emotional numbness, a lack of a sense of identity. So the resistant client, okay, we all have those clients that don't seem to progress in therapy. Raise your hand if you have those people or you know people that have had a lot of therapy and don't seem to get any better. So we all know about them. But some characteristics of clients who don't seem to progress in therapy: trauma history. That's almost 100% across the board. Some of them are medically complicated. Sometimes that comes from the distress that they have, and I'm not just talking about stress-related, but if you studied much on mind-body connection, you can see how medical complications can feed into becoming part of the trauma history. Often a disrupted family history, which is usually where the trauma history comes from. Psychotic phenomena, they hear voices. A lot of times they'll say, well, doesn't everybody have a committee in their head that comments on everything? Sometimes they have delusions, and their delusions are kind of ways of explaining their world and trying to make sense of what's happening with them. Some of them have obsessive-compulsive disorders because nothing stays the same because of all the dissociation, so they try to make their world consistent, and it becomes an obsessive-compulsive disorder. Personality disorders, borderline personality, narcissistic, antisocial, so forth. Brain issues. Some of these people have had brain injury or birth trauma or in the womb trauma, and the cognitive changes and emotional instability is often thought to be some sort of brain damage, which it may be, but maybe not. Maybe a combination. Some of them have seizures, attentional problems. You see poor memory, distractibility, that classic ADD, ADHD complex of symptoms, addictions, eating disorders. A lot of psychotherapy that doesn't seem to have done much. They might have felt somewhat supported in that sense, emotional support in their psychotherapy, but it hasn't really changed the overall mental health issues that they deal with. And they often have many, many diagnoses. And as a result, they often have a lot of medications. So you've got your borderline piece of it, your depression piece of it, your eating disorder piece of it. Or some people just have, 5 or 6 diagnoses and at least that many medications. And I mean psych meds. So what do we do for clients that don't seem to progress in therapy? So we can refer them for medication, maybe for psych testing, for differential diagnosis. Maybe neuropsych evaluation, because after a while, this is so intractable, maybe there's a brain problem. We can refer them to a higher level of care, such as IOP, intensive outpatient, partial hospitalization, or inpatient stabilization. And that is, of course, always indicated if the person is a danger to themselves or others. But it's a stabilization situation, not going to address their dissociative disorder. Then we sometimes refer to another therapist. If this is not a good fit, maybe I should refer to someone else who can have a better connection, or the client connects better to, more knowledge, a specialty area. And if we don't refer, maybe we decide, okay, I can provide supportive psychotherapy, which is based on the number one predictor of good outcome in therapy is the relationship between the therapist and the patient. So I can't make you better, but I can be there for you, can be supportive, I'll be in your corner, and that's the kind of therapy maybe we end up providing because we don't know what else to do. But dissociation can be the root of the problem and can be the source of so-called resistance. We talk about resistant patients. I remember hearing a speaker, a younger person, not in the field nearly as long as I've been in the field, and she was saying, well, she's just not ready for therapy. She's just resistant. And my thought is, maybe I as the therapist need to know more or do more or be a different approach or somehow be more connecting with this person before I blame the patient, before I blame my client. So the DSM-5 diagnostic categories for dissociative disorders are dissociative identity disorder, which is kind of the one we hear a lot about, dissociative amnesia, depersonalization, derealization, other specified dissociative disorder, unspecified dissociative disorder, but they're all characterized by dissociation. And yes, I'm big on diagnosis, but to a limit. Once I see, okay, we have dissociation here, it doesn't matter to me, which one of these you call it. And because of the way dissociation works, it could be any one of these at any given time or move, you just see different manifestations. So the DSM further says that dissociative disorders are characterized by disruption of or discontinuity in the normal integration of these things, which is pretty much what the other definition said. This is a bit more specific: consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. And these symptoms can have the potential to disrupt every area of psychological functioning, decision-making, choices. Many of these people do not succeed in careers, in relationships, as parents. On many levels, their families become very frustrated with them, trying to help, can't figure out why this keeps happening. So they are really re-traumatized by all of these responses to their problems. It adds more trauma. So the history of the diagnosis of dissociative identity disorder, it was thought to be demon possession or some sort of possession from outside the person. And we know in the scriptures, Christ and the apostles healed people of evil spirits, things like that. It's very possible that in that mix that there were some dissociated folk. So that was the earliest label given to people who had a dissociative process going on. Hippocrates used the term hysteria, not necessarily for dissociation only, but which referred to the wandering uterus. The uterus, and of course only women have hysteria, right? So the uterus is wandering around the body and causing all this instability, emotional outbursts, different personas emerging from this person. In the 1800s, you started hearing terms like dissociated personalities, disintegrated personalities. And then we came up with split personality because, they figured out it's inside the person, not necessarily something from outside coming to inhabit the person, but there's something inside. And they're split, which means two. But eventually they figured out, okay, there's more than two personalities here, so it began to be known as multiple personality. Now, the two big things in literature, popular literature, were a book and a movie called Three Faces of Eve. Is anybody familiar with that one? That was about a woman with dissociative identity disorder, and it was a big deal that they thought there were three, but later there came to be many more, and I'll explain that phenomenon also. And then Sybil, which is a horrific story of a woman had terrible child abuse and so forth. And in the movie and even in the novel, it's very dramatic. And so if I'm working with someone where they're beginning to understand maybe they've got this dissociation thing going on, I ask them not to look it up on Dr. Google because this is what comes up. And it's very frightening to think that that is who they might be. And eventually has been called dissociative identity disorder. Now, in the 1938, Kurt Schneider, psychiatrist, published the first-ranked symptoms of schizophrenia. Now, these are pretty much the same as dissociative identity disorder. And so once this diagnosis of schizophrenia was out there, pretty soon you don't see much DID being diagnosed, and it was never heavily diagnosed anyway. But that definitely, incidence of the diagnosis of DID goes down, and then you have the rise of the diagnosis of schizophrenia. It's very possible that many people that are diagnosed with schizophrenia, heavily medicated, in and out of psych hospitals for stabilization, could have dissociative identity disorder. Once a therapist has some training in this, one way to distinguish this is if their voices do not respond to the therapist, it's probably schizophrenia. But if they will talk to the therapist, it's DID. And I want to say as a caveat, in the way I treat it, we don't spend a lot of time talking to alters, but you do have to know that one is there, at least one, in order to make the diagnosis. So now we have the rise of schizophrenia and lots of medications. I'm going to tell you about some of my cases, but I will tell you about one young lady at 15, I believe. She started being very depressed, and her mother took her to the psychiatrist. And she had a nurse practitioner there, and they put her on some depression medication because, she wanted to hurt herself. And then the nurse practitioner says, well, you have to go to therapy, too. So then she comes to me, and I'm talking to her, and I did a checklist, which I'll discuss in a minute, and I see something's going on inside her head, intrapsychically. And I could see when she came the first time with her mom, she was just responding to something intrapsychically. So after talking to her a little bit by herself, and we talked about, she said, I was an A student in honors classes last year, and this year, I'm failing everything. I can't get my work done. I can't focus in class. My thoughts just go on and on. I lie down to go to sleep. I can't stop my brain. So we're talking about, well, what are you hearing? Well, there's this one that says this, and there's this one that says that, and then there's the angry one, and, and she's really describing parts. And so I worked with her in this kind of therapy that I'll talk about in a minute. And really within about 6 months, she wasn't hearing voices at all. Now, after she figured out she was hearing voices inside her head, she tells her mother, I'm hearing voices. Her mother took her back to the psychiatry office, sits with the nurse practitioner. The nurse practitioner now prescribes 4 medications. We've got some antipsychotics, anti-anxiety, depression, all these things. So when she came in the next time, I said, well, how are your voices? She said, well, I still hear them. They're just not as loud. So medication was not going to help her, except maybe calm her down a little bit. So I did this work with her. Now she doesn't hear voices. One day she came in and she said, I can do decimals now. I said, what? I can do decimals now. I couldn't do decimals before. And that is because the learning of decimals was in something that was walled off, which I'll show you a graphic in a minute. But I have seen this with several people, that knowledge of specific academics is gone and then it comes back. And it's just a joy to watch. And we do know, for example, that children who are raised in chaotic environments often have learning disabilities, so-called learning disabilities. And we think, it's their brain, we have to put them on medication or put them in a special classroom. What if it's some sort of dissociation and they've got all this in their head about what's happening at home and all their fears and so forth. The history of the diagnosis of DID is intertwined with the history of hypnosis, because hypnosis has been used to treat or to attempt to treat DID. Again, we'll talk about treatments in a minute. So what is the prevalence of DID among adults? This is a study in a small U.S. community. They found that overall, 1.5% of males had DID. Of that, 1.5% of everybody, but 1.6 males, 1.4 females. Possibly the difference there is due to perhaps people who've been in war zones or daredevil kind of stuff young men do sometimes, getting themselves into traumatic situations. We don't really know. But the U.S. population, as of today, is 325.7 million people. So if we do the math, That means that we have almost 5 million people in this country with dissociative identity disorder. If you divided that by the 50 states, if these people were evenly distributed across all the states, which we know they're not because population differs, but that would be about 98,000 people per state. Now, I took my greater Orlando area of population of 2.13 million and did the math, and that means there are about 32,000 sufferers with DID in Orlando. And studies show it's greatly undiagnosed in clinical populations. So people who are in outpatient care, whether it's therapy, IOP, PHP, or inpatient, many of those people are undiagnosed with dissociative identity disorder. So when we expand the perspective, we need to understand dissociation is a defense mechanism. We are fearfully and wonderfully made, and our brain takes care of us. Our mind takes care of us when something is too awful that is happening, that we are going to wall that off because it might kill the body. And again, if you study the mind-body connection, you will get more insight into that aspect. But we all dissociate. Come home from a hard day, sit down, put something on TV, sports, HGTV, whatever it is, chilling out, watch a little TV, feel a lot better, feel more relaxed. We have dissociated. We have taken our mind somewhere else. We dissociate to one extent or another. Or another one is what they call highway hypnosis. You know where you started out and you know where you ended up and you know even which route you took, but you couldn't tell anybody. I stopped at that light and there were 4 yellow cars over there and there was a taxi and a bus. You just did it and your mind was somewhere else once you learned to drive, actually. Dissociation is on a continuum, with DID being the far end. And even among DID people, there are some variations. But on the low end is what I would call a simple dissociation. So I will tell you about this particular case. And I learned so much from my clients in working with this. But this man came to me because, again, depression, anxiety. He's a middle manager in a retail environment. And he had a needle phobia. He did mention that along the way. And then another thing he mentioned was that he just could not get this incident out of his mind of when he was maybe 10 years old. And his father was a supervisor in a blue-collar environment, and the father had to correct one of the other employees, and the guy beat him horribly to where he ended up in the hospital nearly dead. So this is a trauma for this young man. He's seeing Dad in the hospital and hooked up to machines and tubes and, taking blood with needles, things like that. And so they get Dad put back together pretty much. He goes home for further recuperation, and he has some sort of other medical crisis. I don't know, it was a blood clot or something. A few days later, back in the hospital again. So this was very traumatizing for this young man. And so this is where I really listen. I trust God has to tell me, what people need. He's not dissociated that I can tell into different personalities, but something is stuck. He's stuck there. So I did this particular therapy, which is, you'll see, I'll talk about it in a minute, but kind of a hypnotic patter. It's just a simple thing. I said, close your eyes, step inside to your right. Can you see that 10-year-old boy? Yes. And then I did what we call the joining ceremony, and let this become part of you and all the sad, angry, depressed, negative feelings, go out of you like a vapor into the sky and fill it with the love of God or the love of the universe, depending on the person's orientation. So that's a quick summary. But anyway, so I did this, and he looked up at me, and he kind of cocked his head to the side, and he went, And then I didn't see him for several weeks. And I thought, well, I think he's probably really better, but I don't really know. And then he called me for another session. He came in, and he said, you are going to be so proud of me. I gave blood. Didn't bother me in the least, and I have an appointment to do it again. Needles do not bother me. So that was part of this, some sort of dissociated part. And he said, and I haven't thought about that situation with my father since. And he thanked me. And, of course, I'm thanking God, for being able to help him. So it's really wonderful. So there is a continuum. See, he was on the small end of dissociation. But some people have an overactive ability to dissociate. It is a defense mechanism. It protects us. But for some reason, some people do tend to do this. And is it genetic? Possibly, because we know some people are more sensitive temperamentally. Think of the people that have sensory overloads, people that are kind of prone to little things upset them easily. So sometimes we see it in families. Could be genetic, could be learned. This is how everybody else in the family copes. Could be environmental. All of a sudden I'm in a war zone or I'm in this really bad situation. And that is dissociation-worthy type of experience, so that they're not just overreacting, but something horrific has happened. And dissociation happens with major traumatic events, which is like Sybil and these kind of stereotypic things. But it also happens with seemingly minor events. Perhaps as a child, somebody said something unkind to the child. Maybe he was picked up a little bit late from daycare. Maybe as an infant he cried a little bit longer, than he wanted to. He felt abandoned as an infant. We don't know. But it can be something that, we look at from the outside. Oh, it's not a big deal. But it's about how the individual interprets it. And dissociation begins in early childhood. If not before, it can start in the womb. I have seen a few things that suggest to me that people who are conceived by IVF, in vitro fertilization, conceived in a petri dish, may have some. I actually had a patient once that was the only trauma I could track it to. And it was very interesting because she was a twin. Her parents, went to great lengths to have their children. And the other one was a boy, and it died in the womb. And her mother told her when she was 2 years old, she asked her mother, "Where's my brother? What happened to my brother?" Yeah, wow. So we are fearfully and wonderfully made. Can begin at conception in the womb. I have another case where adverse environment in the womb, the person responded to that, the fetus. And what other defense mechanism is there in the womb for early childhood? They can't turn around and run from a situation. How do they get away? How do they escape? So an expanded perspective. This is a quote from my mentor's book, Dr. Earl Flora. I train with him. In fact, after this, I'll be going to train some more. He says, "I believe the subconscious mind interprets various life events as they are too stressful for the conscious mind to handle. The subconscious mind believes the system could not survive," and the system being the whole body as well as the psyche, all of it. Okay. The system could not survive with that much stress in the conscious mind. To prevent the body from fainting or being paralyzed in a state of shock, an amnestic barrier is lowered in an instant, blocking prior life history from the non-conscious mind. Okay, so it's the emotions that we are dissociating from. Okay, and he further says, "Since there is no past history available to the now new conscious mind, all it can do is observe the environment from that moment on to try and make sense out of the moment. When these events get walled off, it takes that history. The now new conscious mind only lacks personal history. The now new conscious mind is able to use the body to fulfill its physical needs. It has vocabulary, but no sense of personal identity to guide its use. Without history, there is no wisdom, so decisions and actions take place almost helter-skelter, unless the inner voices guide and direct their actions." So just like the young woman who lost decimals, that was blocked off. When these splits happen, life history goes away, is not able to be accessed, except that you have these split off parts doing things, which I like this graphic. This is one way of explaining the DID mind. So this is the conscious mind, all right? You have your subconscious mind, which knows everything, and there are different conceptions of these parts of the mind. But this big area we call this the core. Usually the core is the person who comes into therapy, who makes the appointment. These are split off life experiences. Traumas have happened, and these barriers have come down. And these barriers are preventing the core from feeling these events, feeling the emotions of them. And every so often, we call these alters, I also call them personas, the person will so-called switch and become a different person. And they're really good at this, often subtle, but sometimes not. This is where I've had some spouses say, I never know who I'm going to wake up to, because they're different. Because one of these hops into the conscious mind and takes over. So this one is angry about something that happened in childhood when they're too young to be able to express it or to get help for whatever it is, hops into the conscious mind. Now that anger, think of anger of a 2-year-old, kicking and screaming. Well, in an adult body, that is pretty scary. So this hops into the conscious mind and takes over. I have a friend who told me when she was in college, she had a roommate that had this, and it was a very fundamentalist Christian college. And most of the time, the girl lived in the core, but every so often, one of these would happen to take over the conscious mind, and she would dress up in a cocktail dress and heels and go out and find men and, do all kinds of stuff for several days. And, but her core personality was, just a nice Christian girl. I have a patient who tells me, she has a name. I forgot the name. When Lulu is out, she'll be out for days. I don't know what she does. I can tell when she's been out because everybody's mad at me. And I don't know what she did, but I just apologize for everything. So she has some knowledge that something has happened. I tend to use the term personas because that's a little more neutral than the word alter because of what you find on Google. So I've told you about Paul with the needle phobia. This is Jennifer, the high school student, and I pretty much traced the source of her trauma. She was the daughter of a very young mother, and this mother struggled to take care of them, the two of them. And this little girl lived through all mom's struggles and worries. And, mom didn't have a lot of coping skills, so she's, I'm sure, showing her distress. And then, trying to stabilize her own life, had some not so good boyfriends and so forth. And so this little girl is living through all this. And so the first time they came, I forgot I wasn't talking about the copay. I can't remember what it was. The mother was talking about going somewhere, and the daughter looks at her and she says, "Mom, we can't afford that." Meanwhile, mother's an executive now. Mother is very well fixed financially. And the daughter lives that well-fixed financial life as part of the family. But she had gone back to one of those early parts of her life when she was traumatized by the struggles of her mom. So once again, from the outside, we might say, well, the mom took care of her. She always had clothes. She had food. What's the big deal? Well, it was how she interpreted it. Max. This is one of the extreme dissociations. This man suffered trauma in the womb. His mother had a medical condition. The environment of the womb was hostile to him. And he struggled with attention, memory, emotional problems all his life, and it was thought that he had brain damage from this. In fact, if you read this condition online, they'll talk about it, this or that part of the brain is damaged in these infants and so forth. But this person got this kind of therapy. He has attention. He has memory. He is not brain damaged. Now, the older people are, the more this dissociation has happened in their life, the more they have to clear out and work on and join and so forth. But it's a miracle. This is somebody I know personally. I did not do the therapy with this person. This is one of my patients. This lady, 57 years old, you would say her biggest trauma was the fact that her father stabbed her mother to death. But nobody, where that happens, nobody has been without trauma previous to that. So her whole life was trauma. And she worked for a company for like 22 years. And all of a sudden, she started having a breakdown. She couldn't function. All these thoughts. She had thoughts of jumping off a bridge where a bunch of alligators are so she could commit suicide that way. Nobody would find her body, and therefore she wouldn't trouble anybody. And it seemed to trigger these dissociated parts of her coming out when she got a supervisor who started demoting her, partly because of a rivalry. This woman had worked there so long and had a lot of knowledge of the history of things in the company, and when the new supervisor wants to change this or that, this woman would say, well, we tried that in the past, and it didn't work. So the supervisor apparently took a dislike to her and started manipulating for her to lose her position, and this is just right back to her childhood. So we are continuing to work on this. So when we look for clues, okay, if they have a trauma history, this is the same list. If they have any of these things, these are the clues. Again, you're gathering information. None of these by itself can tell you, oh, yes, this person has dissociative processes happening, but it's the beginning of the clues. Then there are these checklists, which are very good. There are a lot of checklists about trauma, which, again, looking for, if there's trauma, there could be dissociation. There's the Dissociative Experiences Scale, DES, which is published, but I saw it free online the other day. And then Dr. Flora in his book has these checklists, which are a compilation. And the individual one is when you're interviewing the person one-on-one, you ask them if they experience these things. External one is if somebody's saying, my husband, does this or that, and he's very erratic, and you can ask the spouse the questions about the one and see if there might be something there. And then Dr. Putnam, this is also published in Dr. Flora's book, but Frank Putnam, if you know that name, psychiatrist, has the child dissociative checklist, and that's very helpful. I see people writing down. I'll pause for a moment on the slide. Okay. But they're all in Dr. Flora's book, which is, you can get it on Amazon either in print or electronic. Okay. So some of the items, though, that are on these checklists that access the characteristics of DID, things like finding things in your belongings you didn't remember buying, finding yourself in a place you don't remember how you got there or why you're there. You know, I'm in the grocery store. I don't even know what I'm supposed to be buying here. That's one thing the lady that Linda experiences quite a bit. Max had this phenomenon, looking in the mirror, at least earlier in his life. He said, I would look in the mirror and I didn't know who that was. It's very interesting. Losing time. You see the dripping clocks here. Kind of coming to yourself and saying, wait a minute, what am I doing? How did I get here? And what is oh my gosh, it's 6 hours later or 3 days later. Hearing voices inside the head. The voices are commenting on behavior. Lots of thoughts of death or dying, and a lot of that comes from the fact these personalities get mad at each other. I know this sounds really weird, but they get mad at each other, and they want to kill off each other. And some of them try to harm the body because they don't realize they're all in the same body. They think, if I kill off this one, then there'll be no more problem from that one, but then they kill the whole body, and the whole system dies. These people have a strong fantasy life. They can find evidence of having done things they don't remember doing. The feeling is of looking at things as through a fog. And a really strange one, and I have seen women, I remember one woman that had this where people would come up to her, like men would come up to her and say, hey, baby, and call her by another name, and she didn't even know who they were, and they acted like they knew her. But you know, when one of her other alters was out, she was hanging out in bars, I think. So some of your diagnostic concerns, you can't use the diagnosis until you have evidence that there are two more distinct personality states. And then there's, the DSM talks about differential diagnoses, other things it could be. But once you know what to look for, you'll see that dissociation is involved in far more cases than the literature would predict. And I am not saying it's complete dissociative identity disorder, because just like the middle manager in retail, you know, he's not a full-blown DID, but he had the dissociation, and it is on a continuum. So we see again Paul, the retail manager, versus Linda at the more extreme end, and Max also. So some of the cautions, okay, I've gone over these, but it's really important to have training and a mentor, because I could not do this work if I did not have that. But this diagnosis is unfamiliar to most mental health professionals. I had a woman recently, she said, I'm always trying to keep this together in my head, and that's her description. She goes like this, like there's just so much in my head, and she ended up getting suicidal, and her husband sent her to the hospital, which was fine. But now, after going to IOP and PHP and all that, she texted me the other day, and she says, but, you know, they don't see any markers for DID. Well, it's because they don't really know what to look for. So the treatment that I'm going to talk about a little about is also unfamiliar to people. I go to a group of people who treat DID, and I've had to tell them, forget everything you think you know about doing this kind of work if you want to understand what I'm talking about. Some other complications is, you know, they get antipsychotics, but ADHD medications. I had this one lady who said, I can't concentrate. I have to take ADHD. And I have to take Adderall. And she had taken so much of it, and she was out of it. You have to go beg my doctor for some more. Finally, I sent her to drug treatment and detox because, you know, she's dissociated, but she kept overdoing the Adderall, and even after that treatment, she came out and got into it again. And I have another one with the benzodiazepines, something similar. She's conned her doctor into prescribing like 6 milligrams of benzos a day. It's supposed to be as needed, but she takes it all the time. And yes. Ativan, Valium, Librium, Xanax. They're called minor tranquilizers. They're used for anxiety, but generally they're used as a bridge where the physician puts the patient on an antidepressant that also manages anxiety because it's the same biochemistry as depression. And they use the benzodiazepines as a bridge until that antidepressant fully kicks in. And clients have their own metaphors for what's happening. So this one woman is always telling about her eating disorder issues, which she sort of does, but it's really bigger than that. And she's got lots of medical metaphors. And then that particular one also, though, she does have a head injury, but she is also dissociative. So we've got lots of things happening with her, and it's been really hard to tell what's what. So some common treatments. Most treatments require the client to go through abreaction, which is you have to go back and experience all of that again emotionally. And somehow you're going to get some insight. And then this alter will join the core. But this is very traumatizing to the client and actually to the therapist. I can't picture wanting to do that kind of work. And this would take a long time, years and years. And honestly, I have a patient, her daughter her adopted child has DID, and they've just been limping along. The alters will come out and write on the wall. The girl's 23. The alters come out and write on the walls, and, just... Anyway, and a lot of these therapies will bring out the alters and spend a lot of time talking to them. In my DID therapist group, they talk about, well, if the 3-year-old's out, we just sit and play, and if this one's out, we do this. But what I've learned is the more time you engage with the alters, the stronger they become, and you're not helping at all the person get well. And it encourages switching. And also, many therapies these people are given, like dialectical behavior therapy, cognitive behavior therapy, those require willpower and of limited benefit, as you can see, if somebody's always switching personalities kind of involuntarily, and you're supposed to write your feelings down and remember if you have this feeling, you're supposed to do that, and so forth. It's exhausting. And any changes they can make don't last and doesn't come from really inside of them. And DID, dissociation, cannot be treated in inpatient settings. These days, stays are very short, but it takes a long time, longer than an inpatient treatment would permit, for the person and their system of alters to become comfortable with the therapist. And also in those environments, a lot of times, oh, well, so-and-so didn't come in today, so we'll just plug this other therapist in, and that doesn't work either. And it's long-term enough that they need outpatient consistently. So I use whole mind therapy. It's based on the work of Dr. Flora, and I can only give you an overview today because I've spent so much time in my training that I can't possibly, teach all this in 1 hour. But you have to understand the structure of the fractured mind. I use a dissociation checklist in the initial interview for everybody just to see what's going on. And in this kind of therapy, the therapist does a lot of talking, especially initially. I'm used to the kind of therapy where you get the person talking, what's going on with you, what's happened, give me your history and that kind of thing. And we do a little bit about the history. But the therapist talking is kind of like hypnotic patter. You guys know what that is? In hypnosis, you can get whole books of scripts, like the Stop Smoking Protocol, for example, where you put them in a trance, and then you just read this, and it touches everything that they need in order to stop smoking. Now, we do not put people in a trance. So in a sense, it's hypnosis, but it's really not, because the person is coming in already dissociated. They're kind of already in a trance. They live in the trance, and they're very vulnerable and amenable to suggestion. So we accept the client where they are, what they bring to us. We don't have our own agenda. We're not saying, well, you have this trauma and that, and we got to deal with that. We just say, what's going on with you today? And we don't need to know everything. For example, the man, I don't really know why this worked so well with the man with the needle phobia, but I don't have to know that. He's better. I don't have to know everything. And especially we don't disturb their memories. I've heard of some people using hypnosis. Well, they had a bad childhood. I just built in some better childhood memories. That is dangerous and extremely disrespectful to the person. Like I said, we don't induce a trance, but we need to understand the system. It is very real. It is very real. You have to keep track of what the client is telling you. Dr. Flora uses a handwritten form where he figures it out. I have one I use on the computer, so that's where I take notes. I just open it up. I have one for every person with this kind of therapy, and it's the date and, the description of the alter. Sometimes they have a name. Sometimes they're just kind of known by function. And I keep track of, what we join and, what I learn. In this therapy, again, please at least read the book before you attempt this, but definitely get some training. We ask for help. We ask if an alter, and this is long after we have had lots of discussions about everybody dissociates. We make it very generalized. Everybody dissociates to a certain extent. Some people do more than others. And, we're very accepting here, and we're not killing off anybody. You have to be very accepting. It's kind of like you have a room full of children, and if you told them that we're going to kill off 4 of you, they're going to run out the door. Well, it's not about that. It's like we love you, and we're joining you to the core in a very loving way because we need you. We need your knowledge, your experience, your life experience. You have to make sure those alters, remember, and they're children, even though they say they're older, but they're kind of not. And you have to be so back to the co-therapist. You ask for, is there anybody in the system who would be willing to be a helper in the therapy that we might get some information from time to time? And so one will usually step forward, and it's usually an adolescent, because that's the age where I want some affirmation of who I am. And so like with Linda, hers stepped forward, gave me a name actually, and not the same name as Linda, and said yes, that she would be willing to help. And it was a female. You also find alters of opposite sex sometimes in these folks. You may find a homosexual alter, even though the person doesn't act out that, in reality. But you have to be careful of protectors. Because, again, with the thought processes of a child, these protectors are not logical. And so a protector might decide, you're going to hurt the client. And so, we're going to kill off anybody who talks to you, or, which means they start harming the body. Might be cutting or something. So you have to be careful of those protectors. You just have to, again, keep up that very accepting talk. Also, I would call it patter, very accepting of the system. Most of them are children, even though they say they're older. They're kind of like in dress up. And there can easily be hundreds of alters because of every single thing that happens, can be split off again. Which is why the lady with 3 Faces of Eve, they found so many more alters in there, because every life experience, once they've learned to dissociate, everything that's frightening or disturbing gets walled off. And you also have to know there are clients who have been programmed by satanic cults. Satanic cults do not like this kind of work. Personally, I've not yet met one. Thank you. But they will, if they find a therapist who is messing up their satanic rituals and exploitation, they can program somebody to come in and cause a lot of problems and try to harm the therapist. There is what we call a joining ceremony. This is a term used by Dr. Flora. It's found in his book. And like I said, it's a form of hypnosis pattern. But again, we are not inducing a trance. They're already in a trance. And only after the core and the particular alter agree do you do this. Like I said, you can read it in the book. And I did, but I still needed a lot more help for this. And because this is just a short, 1 hour here, I can only tell you we are developing training for this. I have a sign-up sheet, actually, if you're interested in being on our email list. But also because I wanted to have handouts of this, and the printing at the hotel didn't really work. So you can also sign this and check off if you want the presentation. But the family suffers. When we look at the suffering family, first of all, there can be more than one person with DID in the couple. Can you imagine? 2 dissociated people married to each other? But it happens all the time. And, within the family, the pathologies play off each other, and there's lots of chaos. And when the spouse has DID, the other spouse often doesn't feel connected to them. And they don't really know why. This person is so emotionally erratic, and it's so much work to be in this marriage. And they do lots of caregiving. The lady who spent all the time trying to keep things together in her head, her husband had spent so many years caregiving, he's exhausted. He wants out, after 27 years of this. And they're dealing with DID spouses' forgetfulness, the emotions, inconsistencies, their insecurities. And children of a DID parent can learn the same coping skills. They can become dissociative. And also when you look at the studies of impact of maternal depression on infant development, and then you filter in, DID people who are distracted or dissociated from the here and now, it definitely has an impact on their children. And then a child with DID, we have a friend who, I'm pretty sure that the child has DID. She's getting, as a 15-year-old, getting diagnosed with borderline personality disorder. She's self-injurious. She switches. She's different people at different times. And right now they live in another state far away, and she's in an inpatient program. And anyway, we'll see. We'll see what happens.